Welcome to All in All. Imagine you're standing there in the clinic, you've got your patient who really needs you, and then there's this complex machine that's literally their lifeline. This deep dive, it's really geared towards you, the dialysis RN or tech. Maybe you're just starting out, or maybe you just want to, sharpen your grasp of that really critical connection point. We've gathered a whole lot of information machine manuals, clinical guidelines, emergency protocols to really get into the nuts and bolts of the machine-patient interface.
That's absolutely the goal here. We're aiming to distill what's in these sources into the practical knowledge you need day to day, so you can feel confident and provide, truly safe and excellent care. Because understanding that link, that interaction between the machine and the person, it's just fundamental. It underpins everything in the clinic.
Okay, so let's get right into it. When you're there, treatment's running, that machine screen is like your command center. What are the absolute must-watch things on there?
Well, the sources point to several key readouts you're always keeping an eye on. Things like UF removed, that's the total fluid taken off so far, usually in milliliters. Super important for their fluid status. Then there's dial flow, the dialysate flow rate. Elmin affects clearance. Temp, the dialysate temperature in Celsius, that impacts comfort but also diffusion. Conductivity in MSCM. That's telling you about the ion concentration, basically, if the dialysate is mixed right.
Right.
And, of course, blood flow. The blood pump speed, Elmin, how fast their blood is moving through the filter.
And that conductivity, it connects right back to the dialysate itself. It was interesting seeing that the composition isn't just one fixed formula. There are ranges involved.
Exactly. It's tailored. The sources show bicarbonate, for instance, can range quite a bit, maybe 20 to 40 ml in QL, depending on the patient's needs. But sodium, interestingly, often has a standard target, like 100 to 37 ml in QL, although the machines do allow adjustment, usually between, say, 130 on the low end and maybe 155 L in QL on the high end. Knowing those benchmarks helps.
So you have the screen, the numbers, then there's the physical machine. If you're new, just getting oriented, what are the key parts you need to spot quickly?
Yeah, the sources usually break it down. You've got the fluid side and the blood side. Fluid side has your dialysate line connectors. Remember, blue goes to the dialyzer from the machine.
And red comes back from the dialyzer.
Right, and you've got separate connectors for the concentrates, often red and blue too. Then the blood side, that's where you see the holder for the dialyzer itself, guides for the blood lines, the expansion chamber holder.
The drip chamber, yeah.
Exactly. The blood pressure monitor, the cuff holder, usually a top tray for supplies, and the IV pole, the infusion stand.
And the main way you interact is that touchscreen panel. What else does it show besides those parameters we just talked about?
Well, it tells you the machine's current state. Is it doing a check? Is it actually running the treatment? Maybe it's in disinfection mode. It'll show the treatment time remaining, a spot for the BPM reading, and often a button for something like diaskin.
Diaskin. Now, I've seen that. What's the function there, according to what we looked at?
Diaskin, or sometimes it has a different name, but basically it uses connectivity shifts during treatment to estimate sodium removal. And sometimes urea kinetics, too. It's an extra monitoring tool. And yeah, you interact right there, touch the time indicator. You can usually bring up a keypad to adjust the total treatment duration. Hit the BPM button, it takes a reading. But remember, a lot of changes need you to hit confirm on the screen.
Got it. Makes sense. And these machines, they're not isolated anymore, are they? They connect to networks.
Right. For data, updates, maybe remote checks, you'll see Ethernet ports, wireless options supporting different security protocols, and sometimes older serial COM ports for data, or maybe an external touchscreen.
Okay, let's pivot now from the machine itself to that really, really crucial point where it connects to the patient, the vascular access. Needling AV fistulas and grafts. It's just a core skill, isn't it?
Oh, absolutely non-negotiable. And the sources are really clear. The process starts way before you even pick up that needle. It starts with a thorough assessment of the access done by the person actually doing the needling. They call it the look, listen, feel assessment.
Okay, break that down. What are you looking for specifically?
So you're visually inspecting the skin over the access, any redness, warmth, old needle sites, signs of infection. Is the skin thinning? You're also looking at the whole arm or leg. Any swelling, aneurysms, anything unusual.
And listening with a stethoscope.
Yes, listening for the bruit. It should be this continuous whoosh whoosh sound right in time with their pulse. And as you move the stethoscope up the arm away from the anastomosis, that sound should get softer, more diffuse.
Okay, and the feel palpating for the thrill.
Exactly. You gently place your fingers over the access. It should feel like a fine vibration, almost like a cat purring, not a hard pulse or a thump. And just like the bruit, that thrill should lessen as you move further up the vessel. A really strong, localized thrill might actually signal a problem, like a narrowing.
And besides that physical check, you need to talk to the patient too, right? Get their history.
Oh, absolutely critical. Ask them about previous needling, what sites worked, what didn't, any problems like pain or infiltrations before. Their experience is invaluable information.
And planning where to stick is vital for keeping the access healthy long term. The sources talk about specific techniques.
Yes, the preferred method mentioned is the rope ladder technique. Basically, you use different sites along the whole usable length of the fistula or graft for each treatment. You rotate the sites.
So you're not hitting the same spot every time.
Precisely. You might move just a little bit above the last site, or if it's a wider vessel, maybe alternate side to side too. The whole point is to avoid area puncture.
Area puncture being just repeatedly using one small zone.
Exactly, which can lead to weakened vessel walls, aneurysms, scarring, makes future needling much harder. Sometimes it might be the only option if the access is very limited, but you really try to avoid it for longevity.
What about the buttonhole technique? That sounds different.
It is quite different. With buttonhole, you meticulously create a fixed tunnel. You use sharp needles at the exact same spot, same angle, for several sessions until a track forms. Then you switch to using blunt needles that follow that established scar tissue tunnel. The sources generally say this is for AV fistulae, typically not for grafts because of a higher infection risk with grafts. And consistency is crucial. If the patient misses treatments, that track can kind of close up and become difficult to cannulate again.
Okay, so assessment done, history taken, technique chosen. You're ready for the arterial needle insertion. Walk us through the steps highlighted.
First, patient hand hygiene is key. Then you clean the site really well with disinfectant. Octanodyne was mentioned following your clinic's protocol. Staff put on gloves, could be sterile or non-sterile depending on the exact policy, and use safety-engineered needles. You hold the needle bevel up, use your other hand to pull the skin taut just below the spot you're aiming for. Insert at roughly a 25-degree angle. Then, the crucial moment, you see that blood flashback in the hub. Once you see the flashback, you lower the angle, make it almost parallel to the vessel, and gently, slowly advance the needle the rest of the way in until it's secure.
And there's a really important guideline if things don't go smoothly right away.
Yes, a critical safety point emphasized. If you make 2 unsuccessful attempts to insert the needle at the same site, you need to stop. Don't keep trying there. Ask another qualified colleague to attempt it.
That's so important, especially for newer staff. It takes the pressure off. And speaking of pressure, needling can make patients really anxious, can it? Especially if they're new.
Oh, definitely. Empathy is huge here. And the sources even mention involving patients more in their care, like teaching them self-cannulation.
Really? Learning to stick themselves.
Yeah, with careful assessment, training, and ongoing support. It covers everything: hand hygiene, applying the tourniquet, the actual insertion technique, taping, flushing. Sometimes starting by teaching them just needle removal can build confidence before tackling insertion.
Interesting. Okay, so needles are in, lines are connected, treatment's underway. Your focus snaps back to monitoring, watching those machine numbers we talked about.
Right, but also watching the patient very closely. You're constantly assessing for any symptoms: headache, dizziness, cramps, nausea, vomiting, even excessive yawning or just seeming out of it, trouble concentrating. These can be early warnings.
So let's say a patient gets dizzy, their blood pressure tanks, that intradialytic hypotension, it happens. What's the immediate response based on the sources?
First thing, stop the ultrafiltration. Hit that UF stop or UF off button immediately. Then help the patient. Lie them back, maybe elevate their feet if possible. The guidance usually involves giving a bolus of normal saline. Maybe start with 200 milliliters, see how they respond. If symptoms continue or their systolic BP stays low, say under 100 millimole HGG is often mentioned, you might give more saline. You might also need to decrease the blood flow rate, maybe down to 200 milligas, just to ease the strain.
And the sources also point to watching the arterial pressure, AP, and venous pressure, VP readings, on the machine itself. What trends or red flags there?
Yeah, you're looking for changes. If the venous pressure starts creeping up consistently, or the arterial pressure becomes less negative, more positive than usual for that patient at that blood flow, those could be signs.
Signs of what?
Could indicate a narrowing, a stenosis, somewhere in the access circuit, maybe in the fistula or graft itself, or the veins draining it.
Yeah.
If you see those trends developing, you need to flag it for the nurse or doctor. It might mean they need a fistulogram or other tests to check the access.
It's amazing how those pressures link back to the physical access. You also mentioned UF, the fluid removal can be done in phases.
Yes, sometimes you might use what's called an isolated UF phase. This lets you program the machine to remove a specific amount of fluid over a set time without the main dialysis process happening simultaneously.
So just fluid removal.
Right, just fluid removal. That volume counts towards the total goal. Once that isolated phase finishes, the machine usually switches automatically back to the regular combined diffusion and UF treatment. And importantly, you can usually deactivate that isolated UF if the patient isn't tolerating it well.
Okay, so the treatment runs its course, time's up, you confirm it. Then comes rinse back. What's the basic procedure there?
You hit the rinse back button on the machine, the blood pump stops. Then you disconnect the arterial blood line from the patient's arterial needle. You connect that arterial line to your bag or bottle of sterile saline solution. Then you restart the blood pump at a safe prescribed rate. The saline pushes the blood remaining in the circuit back to the patient through their venous needle. You continue until the lines look clear of blood, or maybe until a specific volume of saline has been infused according to your protocol.
And if you need to cut the treatment short for some reason, before the full time?
Usually the procedure is just to manually adjust the treatment time remaining on the machine's display down to 0.0, so that effectively ends the timed portion.
Okay, now let's talk about when things go wrong. Complications. What's a common one the sources highlight? Needle infiltration seems big.
Yeah, infiltration. Sometimes called a blown needle, though that sounds a bit dramatic. It's when the needle tip basically pokes through the vessel wall. The patient might feel pain, you'll see swelling, maybe a lump forming near the site while the pump is running. If that happens, you have to stop using that site immediately. It needs time to heal. If you are using a rope ladder approach, you find a completely new site. If you absolutely can't get another needle in safely and comfortably, well, the sources say you have to weigh the risks. Can the patient safely miss this treatment? Or do you need to try a different approach, maybe involve someone else? It's a judgment call.
What about bleeding from a site during the treatment, not infiltration?
The guidance suggests applying direct light pressure with gauze over the bleeding spot. Hold it for about 5 minutes. If it doesn't stop or slow down considerably, you might face a tough decision. Either end the treatment early or perhaps initiate circling the blood.
Circling meaning?
Meaning you disconnect the lines from the patient but connect them to each other, possibly through a saline bag, so the blood just circulates within the machine's circuit without going back to the patient. It buys time while you manage the bleeding site. And related to this, venous needle dislodgement is always a major risk. The sources stress machine safeguards and using those needle safety devices.
Okay, tricky scenario. The venous needle infiltrates. How do you get the blood back safely then?
That's an urgent situation. First, stop the blood pump immediately. Clamp both blood lines, arterial and venous. And crucially, clamp both needles right at the skin. Then, you carefully disconnect the arterial blood line from the patient's arterial needle. Attach that arterial line to a special sterile saline spike, often a red Y connector. Then you can infuse saline into the arterial line to push the blood back towards the patient through their still good arterial needle access. You bypass the infiltrated venous site.
I see. Makes sense. What about catheters? Clotting seems common there.
Very common. If you can't easily infuse saline or draw blood back from a dialysis catheter, it's often clotted. The sources mention using thrombolytic drugs clot busters like TPA, which has the brand name Cathflow. You instill it right into the catheter lumens to dissolve the clot.
Moving beyond access issues, the sources also covered more systemic problems. Dialysis disequilibrium syndrome, DDS.
Right, DDS. It's much rarer now with modern practices, but still something to know about. It typically happened in patients starting dialysis who had extremely high levels of waste products, like BUN. Symptoms range from nausea and headache to confusion, even seizures in bad cases. The main theory mentioned is that dialysis removes urea from the blood faster than it can shift out of the brain cells. This creates an osmotic imbalance, pulling water into the brain, causing swelling.
Wow. Another one was hemolysis damage to red blood cells. What causes that?
Several things mentioned. Kinked blood lines creating too much negative pressure, dialysate that's way too hot, or even chemical contaminants in the water supply, like copper, were cited as potential culprits. You might see the blood turning a port wine color.
And allergic reactions, anaphylaxis. Though rare, they're emergencies. What triggers those?
Yeah, rare but serious. Causes can include residual disinfectants if the dialyzer wasn't rinsed properly, Reactions to heparin sometimes related to HIT, heparin-induced thrombocytopenia, which is a specific immune reaction, leftover ethylene oxide from sterilization, and even reactions to the dialyzer membrane material itself. The AN69 membrane was specifically mentioned, sometimes causing issues in patients also taking ACE inhibitor blood pressure meds. Symptoms can be tricky because they vary widely and might mimic other problems. Constant vigilance is key.
And the machine itself helps with vigilance through alarms. Some seem more routine, others critical.
Exactly. You might get a message like default rinse times. The sources suggest this usually means the machine lost its custom settings and needs a service tech visit, but isn't an immediate stop treatment crisis. But then you have alarms like dial valve failure, or if the machine just cannot get the dialysate to the right temperature. Those are often critical. It usually means stop, return blood if safe, and take that machine out of service immediately for repair. It really highlights how crucial the dialysis techs are, monitoring those machine functions constantly.
What about the clinic's lifeline, the water treatment system? If the RO, the reverse osmosis machine, fails?
That's a code red situation for the clinic. The protocol described is clear. Immediate notification, up the chain, head nurse, physician, etc. Get the RO engineer contacted ASAP. Document everything meticulously. But it also underscores why routine water quality checks are so vital. Things like water temperature, hardness, chlorine-chloramine levels, TDS, bacteria counts. These are monitored regularly, sometimes daily, sometimes monthly, with logs reviewed. Plus, monitoring the UV lights and ultrafilters that help purify the water.
Okay, changing gears slightly but fundamentally linked.
Mm-hmm.
Infection control. It's just woven into every single action for an RN or a tech in dialysis.
Absolutely. You cannot overstate it. Strict aseptic technique all the time. Good hand hygiene, proper skin prep before needling, those are the cornerstones. And gloves are mandatory, with double gloving specified for hepatitis and HIV-positive patients according to the sources.
And caring for patients with known infections involves specific isolation procedures.
Yes. The sources describe using designated machines, sometimes separate isolation rooms, maybe even with physical barriers like glass walls. Strict adherence to PPE is essential. For emergencies with, say, suspected HIV-positive patients, one approach mentioned was scheduling them last, minimizing staff exposure. Any needles or instruments used for known infectious patients need separate disinfection and autoclaving, and equipment kept in isolation areas stays in those areas.
Waste management is another huge piece of infection control. Very specific protocols there.
Extremely specific. Color coding is key for segregation. Black bags for regular dry trash, green for non-infectious wet, yellow for infectious or anatomical waste, yellow with a black stripe for chemical waste, and red puncture-proof containers for sharps. Those sharps containers need the biohazard symbol. Highly infectious waste might need special treatment like autoclaving before final disposal. Even liquid waste, like for machine disinfection, has rules about safe discharge.
And putting on PPE correctly isn't just throwing it on, there's a sequence.
Right. A specific order is usually recommended for maximum protection. Typically, hand hygiene first, then gown, then respirator or mask, making sure you do a seal check if it's a respirator, then eye protection, face shield, or goggles. And lastly, gloves, pulling the cuffs over the gown sleeves. And knowing how to handle spills, particularly blood or body fluid spills, is critical too. Contain it, disinfect properly, allowing enough contact time, then clean up and dispose of everything as medical waste.
Lastly, the sources touched on some wider clinic operations.
Yeah, things like making sure you have the right consent forms routine versus emergency consents can differ. The role of the physician on call for handling emergencies and backing up staff, the head nurse's responsibilities overseeing care, training, admin tasks like checking charts, updating policies, handling complaints, and also the need for regular technical safety checks, the TSIs, on the dialysis machines themselves with proper documentation.
Wow. That was certainly a comprehensive dive, covering so much ground from the machine settings to complex troubleshooting and safety protocols.
It really does highlight the sheer breadth of knowledge and the range of skills that dialysis RNs and techs need. You're managing technology, performing intricate procedures like needling, monitoring patients closely, handling potential crises, and maintaining rigorous safety standards, especially around infection control.
It's such a critical role. It demands sharp observation skills, the ability to think fast on your feet, and of course, a lot of compassionate care. The machine is the tool, but really, you are the vital link making it all work safely for the patient.
Exactly right. This knowledge, understanding these interactions from the machine parameters to the patient's response, it really forms the foundation. Mastering all these elements is truly key to providing that high-quality hemodialysis care.
Definitely something to keep in mind as you continue your journey, whether you're starting out or years into your dialysis career.
Thanks for listening to All in All.